afternoon, everybody. Thanks so much for being here in person in Sheldon Hall or online. A number of people have joined us online. It's great to see everybody. And as you know, this series is a chance to hear from our newly appointed and promoted professors as well as our senior scientists. And I always look forward to this particular occasion, and I'm sure you do as well. But they seem particularly important and welcoming at this point in time as we struggle with uncertain times and deeply disruptive changes in federal support of science and public health. I'm truly grateful for the opportunity to hear firsthand from our faculty about their life-saving work that we know is so important. I'm glad you are here to listen and to learn from a wonderful, wonderful colleague. So it is my great pleasure to introduce today's speaker, and that is Agbessi Amouzou. Agbessi is a professor in our Department of International Health in the Division of Global Disease Epidemiology and Control, and a core member of the Institute for International Programs. An experienced demographer, Agbessi is helping us to better understand and address the health and mortality of mothers and children in low-income settings. Working closely with regional and national partners, Agbessi is bringing surveillance systems for mortality and cause of death to places where they are most needed. He is also committed to evaluating the effectiveness of large-scale maternal and child health programs, helping us determine how to bring our very best solutions to scale. This promising and exciting work all began with a love of math. Agbessi earned a master's in mathematics from the University of Lomé in Togo, and after 2 years of teaching high school, he found an opportunity to study demography in Cameroon. Soon after that, he joined the Family Health and AIDS Project in Côte d'Ivoire, where he helped to advance family planning and HIV prevention. Then lucky for us, he then decided to further his studies right here at the Bloomberg School, earning first an MHS and then a PhD, supported by a scholarship from our own Gates Institute. As a student, Agbessi worked and studied with longtime faculty member Stan Becker, and Stan Becker is here with us in the audience. It's great to see you, Stan. Stan is a professor emeritus, as you know, and it's just so wonderful to see these enduring connections in our community. Stan expressed how tremendously proud he is to see Agbessi building on his work and the work of his colleagues, taking our efforts to advance mortality surveillance to bold new directions. We'll, of course, hear much more of this work from Agbessi himself, but let me tell you very, very briefly about two exciting projects he is involved with. First, Agbessi is working on Countdown to 2030, an ambitious effort that supports monitoring and measurement of women's, children's, and adolescent health in 81 countries. Through evidence and advocacy, Countdown 2030 seeks to rapidly scale up effective interventions that address underlying socioeconomic conditions and boost women's empowerment. Agbessi is also very involved in the countrywide Mortality Surveillance for Action program, also known as COMSA, which is funded by the Gates Foundation. COMSA aims to provide, for the first time ever, annual data on mortality and cause of death in Mozambique. This information, as we know, is the first step to improving lives through effective programs, policy decisions, and resource allocation. The COMSA project is training community representatives, developing new mobile applications for data collection, and using AI technology to improve the accuracy of information derived from verbal autopsies. And that is just this very smallest snapshot of this project, but I'm confident that this groundbreaking project will one day serve as a model for other countries. When we talk about protecting health and saving lives, this is what we mean. Agbessi is taking part in vital, foundational public health work done in deep partnership with those it serves. As Agbessi will tell us, there is tremendous determination and drive in the countries where his research is focused, People are deeply motivated to take ownership of improving health and saving lives in their own communities and beyond. The journey ahead is long, but progress is made every single day. And of course, better data and surveillance, we all know, is the first step towards a healthier world. Professor Amouzou, we are so very, very grateful to have you here today and for all that you give to the Bloomberg School and, of course, to public health. And we're so excited to hear from you. Agbessi.
Well, thank you very much, Dean Mackenzie, for the nice introductions. Good afternoon, everybody. I am very honored by the invitation to give this lecture today and share my works on contributing to accountability for women and children's health. So let's jump right in. All right, let's see. Okay, all right. I show here a number of maps on the distribution of mortality and nutrition. And the far right, you'll see the distribution of countries by income groups. So I'm sure you're familiar with many of these graphs, but what is common in these maps? What we see is poor health and nutrition is concentrated in low-income countries. And despite some progress in the past 2 decades, low-income countries, especially in sub-Saharan Africa, are left behind, counting about a third of the global maternal and child deaths, but only hosting, despite the hosting only 10% of the population. So, this map, on the other hand, produced by the COVID excess mortality group commissioned by WHO, shows the availability of monthly mortality data across countries. So what you see, it's striking, right? Places of high burden of health have the least data. So this is critical in terms of accountability, the contrast that some have called inverse health information law. So to address the lack of data, we do modeling, advanced statistical modeling. And this map is produced by the UN Interagency Group for Child Mortality Estimation. And what it shows is that over half of LMIC countries did not have empirical data in the past 5 years, which means the recent estimates that produced are simply based on extrapolations. So, accelerating decline in mortality must rely on 5 pillars that countries themselves must work on and drive. These include, first, a better measurement that depends on strong data systems, implementation of proven high-impact programs, monitoring of progress, evaluating the effectiveness of health programs, and learning from these steps. When along, capacity building must be prioritized to sustain the process. So what I will show you in the next slide is how I contribute to some of these steps to my work. So let's start with measurement. Understanding mortality levels and trend, disparities, and cause-specific mortality is a priority in all countries, especially low-income countries. And this is reflected in the global framework, such as the Sustainable Development Goals, SDGs. So for measurement, I will focus on work that we have done on measuring all-cause and cause-specific mortality through the Rapid Mortality Monitoring Project, our work in Mozambique, as Dean Mackenzie referred to establish national sample registration systems. And I will also talk briefly about work we have done using mobile phone interviews to measure mortality. So my first large project when I joined the faculty in 2008 here was to coordinate the development of rapid approaches to measure child mortality in real time in several countries in Africa. This RMM project was initiated with support from Global Affairs Canada to develop and implement methods that will produce reliable child mortality estimate on recent short-term period as a strategy for evaluating health programs. The project was led by Jennifer Bryce, working with the Institute for International Program Investigators. If you know about mortality measurement, you understand the challenges we face in trying to measure mortality on short-term intervals of less than 12 months, and using such approach to measure mortality, to evaluate a large-scale program. So we had to make some decisions. First, mortality is seasonal, and short-term changes in mortality may simply be reflecting changes in season rather than changes in the program. So we had to decide that a short-term interval should not be no less than 12 months. Secondly, the reliability of approaches to measure mortality must be tested at small scale before being scaled up to larger areas and used for evaluating effectiveness of programs. So we review all available approaches, including vital event reporting by community health workers, using facility data, doing rapid survey with limited questions on summary birth histories, etc. And we conducted rapid scoping mission to countries, set up partnership with in-country institutions, and identify options in each country that is based on available platform and opportunities. For example, in Ethiopia and Malawi, they already had a cadre of government-paid cadre of community-based workers that we could work with. In Mali, they had volunteers. These community-based approaches consisted in identifying these community-based workers, training them, equipping them to report data on births and deaths within the defined catchment areas. And we're using this to measure mortality. In Malawi and Mali, we focus on 2 districts, and in Ethiopia, we focus on 2 zones. We tested also methods relying on facility data or survey data, but I will focus here on the community-based method. So what do we see here? On the graph on the left, we compare the number of deaths or events reported by community workers to the what we expected within the catchment areas. And on the right, we compare the mortality rate using community-based data that is compared to a household survey with a full birth history. The horizontal line is the equality or adequacy, 100% concordance line. So what we see clearly is that community-based workers picked up only about half of the event in case of Malawi. In Ethiopia, where the catchment areas were generally large, they only picked up only 20% of the event. And only in Mali that we see an acceptable level of completeness. So this underreporting translated into the accuracy of the mortality that were computed, that as you can see on the right. So we draw quite a bit of lessons from this project. First, it's feasible to engage community-based workers to report vital events within their community area. And as was shown in Mali, this is possible, but the Mali case was the smallest in terms of catchment areas and has a high level of supervision. So this suggests that the scaling up of the strategy can be hard and costly. However, in general, we can conclude that community-based workers cannot be relied upon to achieve completeness in event reporting and mortality accuracy solely as an approach. And the approach cannot be used as such as is to evaluate programs. So we found also that some events are more likely to be underreported, such as early neonatal deaths or stillbirths. So building on this experience, we obtained funding from the Gates Foundation to develop a national-level sample registration system in Mozambique to monitor mortality and causes of deaths. This was the first in Africa. Working with the government of Mozambique through the National Institute of Health and the National Institute of Statistics, we designed a system that incorporated key features. We wanted first to have a representativeness, nationally and provincially representative estimate of mortality. We wanted also data to be collected in a continuous manner by a permanent team that has permanent contact with the communities. And data must include cause of death, data collections, and also for sustainability's sake, it needs to be driven by the government and owned by the government. So we estimate that as a provincially stratified sample of 700 geographic clusters was approximately 300 each, was sufficient to generate annual all-cause and cause-specific mortality. We draw randomly these geographic areas from 2007 population sampling census frame. And within each cluster, we recruited our own community-based worker that is trained, equipped to report data on pregnancies, pregnancy outcomes, such as the stillbirths, pregnancy loss, or live births, and deaths of all ages. Another team of about 50 data collectors were stationed at the provincial level, trained to proficiency to collect data on verbal and social autopsy, and they visit the clusters regularly to conduct interviews on verbal and social autopsy on deaths that are identified. The design also incorporated the need to do a complete census of the clusters annually to recapture births and deaths, and update the populations in order to improve the completeness of the event reporting. So the plan also includes an innovation, which consisted of working with the Child Health and Mortality Prevention Project, that's CHAMS, another Gates-funded project, which collected not only verbal autopsy, but also did minimally invasive tissue sample testing, which is a pathology testing that produces much more accurate determination of causes there. So we collaborated with them to use the information to improve the verbal autopsy determination of causes of death. Data are systematically analyzed and regularly released for public use. Though our system was fully digital, that allowed data collection from community and reporting in real time or near real time using mobile phone by community workers. We use tablet to do the lengthy verbal autopsy. And these are immediately transferred to the cloud server. Data can be accessed in real time, analyzed for review and analyzed, and result generated and posted on public website for access. All our clusters are digitized with geo-coordinate of every household. This allows us to actually monitor data collection in real time. So, as I mentioned earlier, verbal autopsy data that is based on record of signs and symptoms, conditions surrounding the deaths, often produce inaccuracies, right? So to improve the accuracy, we pair a verbal autopsy with a MIT, the minimally invasive tissue sample result, and using the MIT as gold standard, we could understand the errors that is in the VA. So that helped create an error matrix that is used to recalibrate the verbal autopsy data in order to obtain a better and improved estimate of cause of death. This innovative approach was led by our own team, biostatistician here, Professor Abi Deta and Scott Ziggers, came up with the Bayesian advanced technique to do the calibrations. So the COMSA system is generating mortality data disaggregated by province, by place of residence. As you can see in this map, we have data for all ages, neonates, under 5 to 14, and adults that we could produce, the system can produce regularly. And most also interestingly, the system produces cause-specific mortality fractions of all ages for neonates under 5 to 14, and 15 to 59 and above. These data are unique, right? Uniquely produced. Countries don't typically have such data nationwide. And it's a breakthrough for Mozambique to generate this regularly for use. So we don't show it here, but we also have data on social autopsy that help us not only to understand the biological causes of death, but factors that are associated with those deaths. This is what we call the social autopsy that goes beyond the biological to understand the pathway to survival. So SRS or sample registration system are not new. They are being implemented in several countries, mostly in Asia, in Bangladesh, in India, in China. They have implemented this system for decades and it's working successfully, generating estimate that they are using. The COMSA experience is first in Africa and leading the way to many other countries. The system is producing comprehensive national, subnational cause and cause-specific mortality and generating an understanding of factors associated with death. The government of Mozambique embraced the system, which is now continuing and serving as a basis for additional studies as was implemented, including a recent sero survey that our team here with Bill Moss has led, and other data collection to assess, for example, the COVID impact. There are challenges, however, in every data collection systems, especially in assuring the completeness and the accuracy of event continuously, addressing field implementation challenges. Fundraising to support the system remain a challenge. However, we show that such a system can be implemented successfully in Africa, at least in Mozambique. So moving forward, we have developed a manual with 12 steps for implementing a sample registration systems, and are currently developing a web-based technical package for the development of such implementation of such an approach in other countries. We are currently providing technical assistance to a number of countries that have received planning grant from the Gates Foundation to plan such a system in their countries, working with a number of global partners such as Valtel Strategies, Africa CDC, WHO, NCHS, Swiss Tropical Public Health, and the Gates Foundation. So when COVID hit and all face-to-face data collection were halted, the relevance of phone-based approaches for large-scale data became critical. So we tested the use of telephone interviews to collect data on pregnancy history of women of reproductive age, a standard approach for measuring child mortality. In Mozambique, we used two options. First, building on the COMSA system, which had established a database of phone numbers, we assessed those phone numbers to make the phone calls. And secondly, we compose phone numbers randomly and dial them randomly, an approach called random digit dialing. So we are able to successfully reach about 24,000 women aged 15 to 49 through these two options. and demonstrated for the first time that the feasibility of implementing a full birth history questionnaire over the phone. We kept interviews under 20 minutes, and this had an acceptable response rate around in the 30%. So the figure you see on the graph compares the COMSA sample of phone numbers, which is in the blue line, and the RDD sample, which is orange, to a face-to-face phone approach, which is the DHS in Mozambique. And you can see that the COMSA subsample produced a fairly good agreement, especially in level and trend, especially in the recent period. But the RDD, on the other hand, show poorer agreement. We are now testing the integration of mobile phone interviews into the COMSA system to add another layer for remote data collection to complement face-to-face interviews, maintaining remote contact with the population and creating greater opportunity for rapid data collection in cases of crisis. So these are some of the examples of measurement that work that we have undertaken. But as you know, measurement, it must be taken forward, but it's not enough. I will share a bit on work we have been doing to monitor progress. And I will focus on the experience of the Countdown to 2030 initiative in monitoring coverage in reproductive, maternal, newborn, and child health, RMNCH, and nutrition and equity in coverage. I'll talk a little bit of how we went about understanding service quality and its impact on coverage, and using routine health information data to monitor coverage statistics. So a major accountability initiative for women and children that we are implementing across all LMIC is the Countdown to 2030, a global partnership of academics, UN agencies, local research institutions, and government to conduct rigorous analysis for monitoring progress in coverage of life-saving interventions, equity, and drivers of RMNCH and nutrition. So it's initiated in 2003 as a countdown to 2015. At the time, the initiative started with a 2003 Lancet series on child survival, Lancet series that many of you know, which drew attention to the unacceptable large deaths among children under 5, despite the availability of low-cost, high-impact solutions. So the initiative was launched by a small group that we see here on the picture. I hope you can see the photo, led by Hopkins faculties, Jennifer Bryce, Bob Black, and several others that you can recognize. The Countdown produced annual progress report in RMNCH and nutrition with a comprehensive country profile available on the web, covering the whole continuum of RMNCH, nutrition, equity, and policy indicators. I joined the initiative about 10 years ago and took over at Hopkins in 2016. So in 2018, we did a comprehensive progress assessment. That was 3 years into the SDGs. SDGs started in 2015, right? So our analysis of progress focused on 81 countries that that accounted for 95% of maternal deaths, global maternal deaths, and 90% of child deaths. And we showed that to reach the SDG, rate of decline in mortality and stunting must accelerate compared to the pace that was observed during the MDG period. The graph that you see here is the flagship countdown graph that shows levels and changes in coverage indicators along the continuum of care from pre-pregnancies all the way to childhood and environment. The arrows that you see on top indicate the recent change in coverage, right? So what it shows is low coverage for family planning, postnatal care, treatment of childhood illnesses. But all across, progress in coverage is too slow. We found specifically that there was extensive variability in progress in coverage of many essential interventions, with too many countries still far behind in achieving universal health coverage. Even for countries that show high coverage, poor quality of services reduce the effect of RMNCH outcomes. Inequality in intervention coverage were reducing, but at low pace. And weak health systems, non-health drivers such as conflict, were major obstacles to delivery of high-quality services to the populations. We call attention to major data gaps that continue to cripple evidence-based decision-making. So in 2020, we published a supplement in BMG Global Health that also reassessed the progress and the commitment to leaving no woman, no child, and no adolescent behind. Inequalities in coverage continue to be unacceptably large in many countries. We discovered that a lack of acceleration in coverage of essential interventions compared to the MDG period, persistent large inequality driven especially by low coverage among the poor, and worrisome stall in coverage of child immunizations, child illness treatment interventions, especially among vulnerable groups such as adolescents and the poor. Here too, we emphasize the urgent need for better data that are sufficiently disaggregated to better understand who is left behind. Last year, we completed another round of comprehensive progress assessment midway into the SDG, comparing progress to the MDG period with the goal of ascertaining whether the momentum needed to reach the SDGs has been sustained, accelerated, or stagnated, or even regressed. The findings are upcoming in a Lancet report to be released in April. But there's no doubt that the SDG period, as we live in it, is facing unexpected strong headwinds, or some will say poly-crisis. We just barely came out of the COVID pandemic. There are emerging epidemics, conflicts rising, climate change threats, stagnating poverties. These contribute to slowing progress and increasing inequality between and within countries. And recent development may further exacerbate these challenges. So we show that progress is not fast enough, and regions like Sub-Saharan Africa were far from achieving the SDGs for mortality. The share of neonatal deaths among child deaths continue to rise, and preterm births have become the leading cause of neonatal deaths. Mortality due to infectious diseases is declining, except for malaria. Coverage of essential interventions was higher in the SDG period, but there was a general slowdown in progress, especially in Sub-Saharan Africa. Inequities remain large and closing more slowly than before. Health financing, health workforce, information systems indicate slow or no progress in health system strengthening. There has not been an increase in aid to countries with the greatest need. So the report also looked at many drivers, and it's very comprehensive, and I don't want to steal the thunder here. And I urge you to be on the lookout for the report in April. But the recurrent theme that we brought out is a major data gap, including the crucial lack of data on maternal mortality, causes of death, morbidity, quality of care, health system and policy indicators where the need is greatest. Addressing these challenges will require sustained global and country investment in health information systems. So a major challenge in progress assessment across all program areas has been understanding and quantifying the level of quality of care provided to women and children seeking services. there's increasing evidence that suggests that quality of care is a major holdback in achieving optimal health outcomes and may explain some of the paradox of near universal utilization of services coexisting with poor health outcomes. So to better understand this, we conceptualize an effective coverage cascade built out of the seminal work that was done by Tanahashi in 1978. The sub-framework sought to quantify and explain the loss of coverage due to deficit in quality of care. The loss of coverage is not only due to accessibility to services, but also the readiness of these services, the actual quality that is provided to women and children, and the adherence of the population to the prescriptions. The framework has also been adopted by WHO. So the past couple of years, our work has been dedicated to analyzing data on various components of the continuum of care to build the cascade and understand the extent to which a reduction in coverage is due to poor quality of care. So consistently across the RMNCH, large increases in service utilization were not met with high quality of care, thus creating extensive missed opportunities. The loss in coverage between contact coverage and the quality adjusted coverage was very large in many countries, more than half of the contact coverage as shown in these graphs. I must also emphasize the fact that quantifying this loss is challenging. The challenges come from data availability, the definition of what quality of care means, and methodological approaches for measuring what quality adjusted coverage indicators are. So perhaps one of the greatest opportunities for monitoring coverage among women and children in low-income countries is the use of routine health information data. However, these data are underutilized for several reasons. Facility use is not universal in most of the countries, and health facility data come from users. So in addition, estimating the appropriate denominator for the target population remains very challenging. So these add also to the concern of quality of routine health information data. What we do in Countdown is every year we work with the APHRC, African Population Health Research Center, to convene multiple countries together to analyze their data and generate results that they take back to the country to use to assess the performance of the health plan. Last year, for example, we brought in 26 countries, 5 representatives per country, and to analyze the routine data. And the table you see on the right show an example of the quality scorecard that the countries produce based on the data, showing metrics of data quality, including the completeness reporting, the assessment of the extreme outliers and missing, assessment of consistency in the data. And on the left, we compare the coverage estimate from the routine data to what is obtained to surveys, household surveys, which are the standard approaches for measuring coverage. And countries can appreciate the quality, the challenges with the routine and try to address them. So uptake of this SSR has been extensive for countries. They go back to organize disseminations and technical meetings with relevant stakeholders to address the findings and act upon them. So these are some of the monitoring work. It's critical, but it's also important to evaluate specific programs, see how they are contributing to impact. I will then turn to work that we have done in evaluating programs. I will draw example on our work doing in-depth case studies to understand drivers of progress, our work in global health exemplar for maternal newborn health. I will also specifically talk about the evaluation of a specific health program, the integrated community case management of childhood illness, that we did in a number of countries, and how we build together tools to build capacity and effectiveness evaluations. So, effectiveness evaluation of large-scale programs are critical to assess whether programs or strategies being implemented are producing their intended result. Rigorous evaluation must be based on a rigorous common impact model, as proposed by Bryce and all here. This comprehensively assess results from input, output, processes, output, outcome, impact, while accounting for environmental, equity, and contextual factors. So one such evaluation that we undertook was to understand drivers of reduction in child mortality in Niger between 2000 and 2010. This stems out of a work that we are doing in Niger, building capacity in mortality analysis with the National Statistics Office in the countries. And if you know Niger, Niger is a landlocked country. I hope you can see on the map in Africa there. And it's usually classified as last in the Human Development Index. So understanding how they successfully reduce child mortality on this period was essential. So we have implemented a case study approach, first in terms of design that actually paved the way for multiple other case studies in many countries. So we accomplished this through extensive analysis of multiple demographic, health, and nutrition surveys, in-depth review of program and health system data, documentation of program and policies, qualitative interviews, and assessment of program policy over the past 15 years, and use of the Life Saved tool to link coverage to life saved. So we found that sustained leadership from the high level that translated into three main areas that were determinant for progress. First, an increase in access to primary health care, including expansion to community management community case management of childhood illnesses. Second, an outreach with life-saving interventions through mass campaign. And third, given the context, an intensified attention to child undernutrition. So these findings were presented by the Minister of Health at the PMNCH breakfast in New York in 2012, ahead of the UN General Assembly meeting, and resulted in further discussion on focusing and sustaining the progress, especially including expanding to newborn health. The findings were also featured in the JHU magazine, as you could see. So a more recent work that we initiated, we undertook at the request of Gate Ventures, was the Global Health Exemplar in Maternal Newborn Health. This aimed at learning from positive outlier countries. These are called exemplar in maternal newborn health countries, defined as those that progress much faster than would be expected compared to socioeconomic progress. We identified 7 countries that experience above average reduction in maternal stillbirth and neonatal mortality, accounting for their gross national income per capita and geographic representations. The study was implemented through a consortium of multiple academics, including the University of Manitoba, the London School, working with in-country researchers. In addition to developing a comprehensive framework, we developed a 5-phase maternal newborn health transition framework, as shown on the left. That was allow us to benchmark countries based on their level of maternal stillbirth and neonatal mortality. We conducted mixed method approaches with extensive analysis of existing data, survey and model data, to derive the factors that drove the progress. The analysis across countries uncovered multiple, as you can imagine, and diverse drivers of progress. But we can summarize them into 4. First, there was a rapid increase in access to maternity services, resulting in an increase in with contact with the services, substantial progress in quality of maternal and newborn care, effects on fertility decline has been substantial, and safer access to safer abortion practices. But countries deploy multiple levers, including progressive implementations, use of data for evidence, and we found that there was no one size fits all. These findings were also presented as a headline presentation in a plenary at the International Maternal and Newborn Health Conference in South Africa in 2023. So large-scale effectiveness evaluation can also focus on specific health programs. This was the case for the integrated community-based management of childhood illness that we evaluated in Ethiopia and Malawi. The program consisted in training, equipping lay community health workers to manage uncomplicated illness among children under 5, focusing especially on pneumonia, diarrhea, and malaria, which were the top killers of children under 5. In Ethiopia, the program was phased by districts. It allowed us to work with the government to build a cluster randomized design. While in Malawi, we started with a quasi-experimental design, but the program moved quickly to cover the entire country, forcing us to use those response type design. We documented the program, monitor contextual factors, measure program strengths and quality midway into the program, assess changes in coverage and mortality through extensive data collections. In both cases, as you can see on the graphs, we did not find strong evidence of large-scale impact in the programs. In both countries, our assessment of the quality of care provided by the community workers was acceptable, even as high or as similar or as higher than the care provided in first-level facilities. However, utilization of the program was low. In Ethiopia, there wasn't any key demand generation activities that was built as part of the program. And in Malawi, the ICCM program was not targeting areas where service utilization for primary health facility was lowest. So in both cases, in Ethiopia, they revised the strategy, the policy to incorporate demand generation activities. And in Malawi, they revised the areas to retarget the ICCM program. So building on this experience in large-scale effectiveness evaluation, we set out to develop, with support from Global Affairs Canada, a set of resources to strengthen capacity for effectiveness evaluation. The RADAR project, that was PI by Neff Walker, aimed to develop tools and materials to effectively respond to key priorities that program managers, decision makers, policymakers, and funders are asking. These are stepwise questions. I will not read them. You could go through them quickly there. But the interesting piece is we have developed a set of tools that go along with each questions, allowing appropriate data collection analysis to answer each of these questions. We have also developed a 6-course series specialization on evaluation of large-scale health programs, available free of charge on Coursera, with options to get a certificate or take individual courses. The course has a good uptake. Have about 8,000 visitors as of this month. A major advantage was the use of real-world examples with field program managers and country collaborators to support the course. So this was a summary of our work in evaluation. For the sake of time, I'd like to close by telling you a little bit about what I've learned and what I think of all this. So a key challenge in global health is a fragmentation and short-term solutions that do not build lasting impact. So I've thought about 4 points. First, success in accountability requires sustained investment in long-term data systems. As we have shown, data was always a problem where the need is greatest. And locally owned implementation and evaluation mechanisms that are able to identify problems, fix them, eliminate ineffective strategies, and find new solutions. Secondly, and related to my first point, there is a need for more actions in mobilizing resources. I know this is challenging in current times, but this is what is needed to move the needle forward. There are too many talks and good intentions, but we need more actions. Thirdly, countries are implementing large-scale programs, and the effectiveness of this evaluation of this program remain essential. This evaluation requires time, resources that are increasingly difficult to find. We must think about new models, efficient way of doing large-scale evaluations that produce fast results, less expensive, less time-consuming. And I hope the rise in data science and AI can be leveraged more to contribute to this. Finally, this talk was not purposely designed for these times, turbulent times, right? And I don't know what the next months or next years are going to be. But like you, all of you, I'm also very concerned, right, about the prospect of continued investment in critical solutions for women and children health. However, we must face and respond to changing global health landscape that started, a few years ago, which demand increasing recognition of the value of low-income institutions and decolonizing global health. This requires building new type of partnership with national health institutions that value trust, complementarity, learning, recognition of mutual strengths and weaknesses. Doing this effectively means defining clearly our role as a high-income institution and where we add more value in this. So I'm glad to see that the Department of International Health has taken the bull by the horn, and new strategies in going to that directions. Well, I think Jean Mackenzie has already introduced me through this. Was born in Africa now. You know about my itinerary already. I think my baby picture still looks like me. So my acknowledgement, I'm truly blessed to have met and be mentored by these public health giants that you can see in the picture here. I hope you can recognize many of them. They do not just talk, but walk their talk and have served as example. All of them have significantly contributed to helping me get where I am today. Stan Baker welcomed me here when I landed for the first time in the US and was my beloved academic advisor throughout and mentor throughout. Well, don't search for the beer if you're looking to see him in the room, because the beers are gone. But we like that picture of the beer. Well, I hope to thank, I also want to thank specifically Jennifer Bryce, with whom I traveled to many countries and has been an intellectual example and a holistic mentor for me as well. This work has been the product of many, many collaborators. Many of you in this room within the Institute for International Program, collaborators in countries, friends, and I'm very grateful. I also want to thank families that opened the door for studies, health facilities that we visited, and donors that really supported these studies. Want to thank my dad, who really worked tirelessly to see me succeed, and my mom, who left very early, passed away too early. My siblings have been very supportive, and I'm very grateful, and thank them. Yeah, my wife, lovely wife, and children have been my greatest and unconditional supporters, and I am very grateful here. And sorry to have put you through many stressful times during trip and studies. And above all, I give the glory to God and who made all this happen. Thank you very much, and take any questions.
Well, thank you so much, Agbessi. I was sitting here thinking this was a master class on how one develops and improves data systems, and then uses new technologies like AI to the benefit of developing those data systems, and then using those data systems to monitor the health of communities and populations, and then taking that to the next level and using it to inform the development and evaluation of life-saving interventions. So you do it all. It's great.
Thank you.
It's very, very well done.
Thank you.
We have some time for a few questions. Of course, Stan has a question. I'll get it. I'll task it.
Very nice, thank you. So the conventional wisdom, at least last I looked, from the UN Statistics Division was that countries can't really have a vital registration system that's very complete until they're in the middle income group or something like that. On the other hand, the SRS, sample registration system in India started, 50, 60 years ago, and it has worked. The problem with that, of course, is you can't get local estimates. And much of your work looked like was using local estimates. And you didn't show us cost estimates, and that's one of the reasons the UN says that countries can't do it until they're middle income. It's just not a priority to have vital registration. But could you comment on that in terms of the cost? Maybe switching to telephones and those things could make it so even poor countries, you talked about Niger, can have at least an SRS system that would give national estimates. I mean, DHS says, well, we have to do our surveys because you don't have good estimates, but maybe that's self-propelling. Anyway, thank you. Very well done.
Yeah, thank you. Thank you. You touch on an important point. One is perennial. CRVS, Civil Registration Vital Statistics. Really, I personally think it has challenges that are different and slightly beyond a nice sample registration system, such as India and Bangladesh. They're doing this because the civil registration system is not only just a data collection system. It's a system for a civil and legal registration. And it has, personally, I think it has been inherited from the colonial period, and they haven't really, come up with a different approach to it. And so it hasn't really taken off. But the SRA, the sample registration system, or any surveillance system, can be devoid from, separated from the legal identity or legal system, politics, and so on, and make works. And that's what's happening. In India, they have the sample registration system, they collect data, they analyze the data, they share the data every year. They don't have to worry about who has a birth certificate or a death certificate and so on, right? Now, that's one of the problems. So I don't think that it necessarily have to be middle-income countries to become, they can be middle-income country and still not have a complete CRVS, unless this is there's a complete to me, a revamping of the CRVS system. But the SRS can be done. And cost, people are always very afraid of cost. In Mozambique, it took us, about a little over $1 million to do, the routine running of the system. The startup cost is slightly higher. I think we end up with $2 million, if I can recall, and it's feasible. If you take a DHS, the DHS is over 5 million and counting. And so these such systems can, once they're started and rolling, they can generate the needed data. But we're also finding it very difficult for funders to come and as you know, it's difficult to put money in data collection in information system because then they don't save immediate lives, and so they're hesitant. They would rather put in money in the program that save lives and forget about the evaluation of the programs. But as we see, you need a data system to produce results. So that's still critical.
Thanks, Agbessi.
Yes.
Thanks. This is wonderful, and also actually, in a way, put me in a very difficult position because Stan was asking me earlier, Agbessi only graduated 2 years ahead of you. Why are you still an associate professor? Well, he's giving the dean's lecture. I was like, he's exceptional. But I have one, I guess, relatively short-term question, but one slightly mid-term question. The short-term question is, with the current climate and the potential disruption to global health, I wonder what are your thoughts on, the system that you're trying to build. Although it's not necessarily funded by USAID, I think there could be, structural changes or structural disruptions there. Could there be any tangible impacts in the short term? And the sort of a midterm question I have is, in terms of the potential or prospect to apply AI and sort of, data science-driven tools or technologies or innovations to SRS or more CRVS systems, what do you see as the potential bottlenecks or challenges in that? I think the technologies or the tools are easier to develop, but I think there may be reservations about the applications or standardization or, I guess, what are your thoughts on those potential reservations or constraints in that area? Thank you.
Well, I'm trying to remember your first question. Let me start from the first one. We just had we got a small grant from the DS data science and AI team. Yeah, we just had this morning a meeting with them, trying to figure out how to better use the data science and AI's approaches integrated in the architecture data system you set up to improve data system. I think that's a way forward. That there is some opportunities there to take advantage of. However, it's important for us to ensure that data that comes in is of good quality. So the system must work. And then the AI or data science approach will help. We're trying to use that to help optimize data collections, data transfer to the cloud server, the analysis, one-click analysis that the countries can do and get results quickly, ability to interrogate the system and get the result quickly. So they tell us there is the whole engineering part that need to be set also in place in addition to bringing AI. They were very much excited. The whole VA, verbal autopsy analysis, we have a lengthy questionnaire, as you know. They have, there's possibility to integrate AI into there, where the questions are auto-generated based on AI. But one challenge also is how do you train? What data do you train this on? It's right that gold standard data is not always available to train these things on. Going back to the first question that I remember now, as I mentioned, we're doing some work to support multiple countries, working with multiple partners. We have colleagues that are working for USAID. USAID is part of supporting some of the countries. So with these things completely in shambles now, we have to figure out what tomorrow is going to be in terms of support, if we can still count on that support, or how this will change the whole funding environment, including other funders, the traditional funders of health systems. So it's going to affect, but I don't have a clear answer on where we're going to go. Thanks.
Great. Any other questions in the room? We do have one question online. It's from Gatwiri. And the question is, are we able to quantify the return of investment using predictive analytics?
Using what? Predicted?
Analytics.
Return investment using predicted analytics. I don't know. I'm not sure I understand clearly the questions. I assume you're saying, whether data analytics, data science will produce usable data results that can be used for result. I mean, within Countdown, we prioritize very much empirical data that countries collect and can relate to well. But also, the modeling, the analytics is critical to generating data for trend, for global use, to understand where progress is going. So return in investment, I can't quantify it this year, but it definitely there. I will not dismiss that. It's definitely work that has been done at global level on cause of death estimation, on modeling mortality, modeling all the health outcomes. It's tremendously useful at countries and global level. I'm not sure I answer your question, but you can reach out to me. You can talk more about it.
Great. Any last question? One more question. There we go.
I think in these politically turbulent times, I wanted to ask a question about politics. The indicators of mortality are hugely politically, are politicized. I think that countries and governments especially aren't interested in showing how high the mortality rates are across the entire spectrum that you showed. And I was just wondering, from your experience with working with many countries and governments, did you face any kind of hesitancy in implementing these surveillance systems to track mortality, which is a huge indicator of their own success, and whether governments, push back on that? From your experience.
Yeah, great point. Yes, I think it's important that the countries themselves be very much involved from the beginning, so that they can, can anticipate the acceptance of the data. But of course, if the data becomes the indicators is not what they desire, you're going to get some pushback. But we're going to look at, you didn't design it well, or they didn't report it well, or something like that. We always face such challenges. But it is important that they are in the seats, the running seat, and they are the one also explaining what's happening. We've seen that only in mortality measurement. We see that in evaluations of programs, right? Where when you come up with something that they're not happy with, they'll push back. Yeah, definitely. Something we have to face, but we need to continue to stay true to the science and get involved the stakeholders from the very, very beginning, share interim results, and educate people as you progress through, so that they know how things are done. It's not a black box. They are involved and they feel some ownership. Thanks.
Great advice. And with that, please join me in thanking Agbessi for a fantastic lecture.
Thank you.